I'm a registered nurse, started in hospice like 40 years ago as a primary care nurse. That's where I learned about end of life because um, in the early 80s, hospice concept was just coming to this country, and there weren't classes or workshop. There was nothing. Elizabeth Kubler-Ross, I spent a week with her in California, in Escondido, um, to learn how to take care of the dying, because there wasn't anything. People died in a room at the end of the hospital corridor, and people stayed away until the person died. So no one really knew what dying was like, let alone how to take care of people when they were dying. Well, Elizabeth's concentration was on you need to know yourself first before you can help others, which was an interesting concept because I went out there thinking she was going to tell me how to take care of dying people, not how to take care of myself. And I think as in the last 40 years that I've been doing this, I realize how very important it is that we take care of ourselves, that we grieve our patients and don't even realize that we grieve our patients. And so we have to put our oxygen mask on first before we can help others. So I was a primary care nurse for 5 years, and that's when I learned how people die. I learned that there are only two ways to die. That's either gradual or fast. You either get hit by a truck, you have a heart attack and you're dead, suicide, you're alive 1 minute and dead the next, or you get a disease, or you're just old and you gradually die. And gradual death has a process to it. And that process is so simple. And it involves eating, sleeping, and withdrawing. You don't even have to know someone's disease to determine if they've entered the dying process or not. And that's what I learned in 5 years. And then I not only was a primary care nurse, I ended up being the director of 2 different hospices. Before the mid 90s, when both of my parents were dying and did die within 5 months of each other. And I realized that I couldn't work with end of life issues and deal with personal end of life issues. So I quit my job as the director of a hospice and thought I can always get another job. I can't always have this experience, which is to be treasured. So and they died within 5 months of each other. And after that, I thought I kind of need a break. I need a rest. And I started getting contact from across the country to do speaking. And that's when I became a teacher. And so from mid 90s to now, I view myself as an end of life educator with writing. All of my materials are teaching tools for families and significant others, as well as those in the healthcare profession that work with end of life. So that's who I am, and that's how I got here. And in case I forget, I have a website, go to it. I write blogs every week. It's part of my community service, so to speak. So sign up for my blogs, you get an email, and it's a form of education.
Alon, if you would put the website in the chat and we can all subscribe to that blog, that'd be great. Um, I'd say let's just get into the questions that the nurses and the HAs submitted.
Okay. Um, how do you get families okay with using the word hospice? 90% of our work in end of life is education. We're the ones that hold the line of truth. When I would go in and make an initial visit, one of the key things that I told families and significant others and patient, if we had the referral soon enough, was that I don't lie, I don't play games, and I will talk about anything. Our role is to talk the difficult talk, and we do it gently but honestly. And so when a family says, don't tell grandma that she's on hospice, don't tell grandma that she can't be fixed, I'm going to educate that family and say, look, grandma knows. Grandma lives inside of her body and she knows she can't be fixed. And what she's probably doing is playing the game with you. She's protecting you because she sees you don't want to talk about it. By not talking about it, what you've done is you've isolated grandma, who's scared, who understands that she's not going to live forever. And you've isolated yourself in that you've denied yourself the opportunity to love and support her. If you talk about it, you're both still going to be afraid. You're both still going to be very, very sad and uncomfortable and all those feelings that you're afraid of, but you won't be alone. Grandma won't be alone and you won't be alone. And by acknowledging that grandma can't be fixed, you're taking the gift of time that you've been given and using it well. End of life, a gradual death, is a gift. It's an opportunity to do and say that which we want to do and say. It's a gift. And that's our job as end of life healthcare workers, is to support, guide, but mainly educate, because we don't have the, not we, people don't have accurate role models on what it's like to die. People have television and the movies, and people don't die like that. But unless you're at the bedside when someone is dying, that's your role model. And so when you look at it through television and the movies, and you see grandma in bed breathing like a fish breathes, making random hand movements and picking at the air and talking and not making sense, you think something pathological is happening. Where if we can educate the family, grandma's doing a good job. This is how you die. And she's doing a great job. Nothing bad is happening. This is very, very sad, but nothing bad is happening. And that's our job as healthcare workers, is to neutralize the fear that all of our families are bringing to this experience. So you use the word hospice. You say what hospice is about. You be real and honest, yet gentle and supportive, nurturing, all of that, because you are bringing uncomfortable news. So you do it gently, with support and guidance, but you're honest. That, I mean, so much of our medical model is not about honesty. And it leaves us who work in end of life to maintain and utilize honesty in our work. Okay. How do you?
I have a question.
Oh, sure.
As far as that conversation about hospice, if someone was to be combative of it, how would you do it in a gentle way? So if I was a family member and I said to you, I don't want to use that word hospice, I do not. How would you talk to them about that conversation?
I say that that is coming from the family's fear of protecting their loved one. And as I said, I don't lie, but I will tell you as a family member that I won't bring up the subject with grandma. But if she asks me, I will talk about it. I won't go in and say, look, you know, and I know that you're dying, and so we're going to talk about it. I'm not going to do that with any of my patients, but I won't play the game of denying the reality of what's happening. But for families that are scared, I reassure them, I won't bring it up. But if she brings it up, then I will talk about it, and I don't lie.
Thank you.
Shall I go on?
Yeah.
Next question. What is the best way to respond to a patient when they ask you how bad it is? I guess I would start with reversing the question and asking them how bad they think it is. I would like to know what's in their head and what prompted the question. Again, based on what they say to me will be how I respond to them. Oftentimes I will say, you know that hospice takes care of people that the doctors are having a difficult time fixing. Did you notice my choice of words? Those aren't as scary as hospice takes care of people who are going to die in 6 months. Hospice takes care of people the doctors are having a difficult time fixing. Our job as hospice is to help a person live the very best they can within the confines that their body and disease has put them in. That's what I'm here for. I'm going to support and guide you with my knowledge through this life experience that you're having. So I concentrate on how we can support them with being honest and truthful. Okay. Since dying is a social communal event, how do we help patients, families, friends feel part of it and complete in an era of COVID, when travel and visitation may not be possible to touch and hold someone? And then getting into rituals after the death. COVID has put us in a state of perpetual grief. We are grieving, not, we associate grief with death, but grief is really about loss. And we have lost so much in COVID. All of us are grieving. And I think we have to totally be aware of that. But in working with our families, there's so many dynamics going on, but I think the bottom line is fear. Pardon me, my allergies are acting up, so my nose is running. I have to catch it.
No problem.
Okay, COVID. During this year, I have recommended to hospices across the country that because families don't want you in their house, number one, because they see you as a healthcare worker as a big risk of getting COVID. So there's that. They can't have their families come. They can't have the grandkids come. If they're across the country, they're not on airplanes. So the isolation has become the key factor in families and people at end of life, whether they have COVID or not. So we in end of life who rely on touch, on closeness, on smile, on sitting on the sofa and holding someone's hand as they cry and putting your arms around them, our major tool has been taken away. And so we have to address right out of the box that our tool has been taken away. And so when you make that first visit and they let you in the house and you're in your mask and you've got your PPE gown on and your gloves on and you're in that home, the first thing you're going to say is, look at me. Look at this. COVID has done this to our country, and I've got all of this gear on because I'm taking care of you. And normally I would be sitting over on the couch with you. You would see me smiling when it was appropriate. You would see tears when you're sad. Because I have this mask on, I'm going to say to you, look in my eyes. You're going to see my care for you in my eyes. I'm sitting clear across the room from you because I'm taking care of you. You won't see me as much as you would if there wasn't COVID, but you and I and the phone are going to become best friends. I'm going to be as close as the phone. And then what you're going to do is, because most of our patients are elderly, and so they don't know how to Zoom. They're technologically challenged, but they know how to work their cell phones. Or if they have a landline, they know how to work that. So here's my idea. You need daily contact with that primary care person who has their loved one in the bedroom and who knows that that loved one is going to die on their watch. And they're terrified. So every day, Monday, the nurse calls. If you're making visits, then Monday, the nurse makes a visit. Tuesday, the social worker calls. Hi, what's going on? How are you feeling? Just having a conversation. This is every Tuesday. Social worker calls. On Wednesday, the chaplain calls. Hi, what's going on? Any questions? Anything I can do for you? And then this is outside the box. You assign a volunteer to become the best friend. The volunteer calls on Thursday. Do you need anything? Can I zip by the store and put it on your front porch? What can I do for you? How was your night? Become a friend. On Friday, the nurse calls again. Most of our referrals are weeks before death. As death gets closer, you're going to increase the nurse phone call, all right? Saturday and Sunday, the volunteer calls. so that 7 days a week, that primary caregiver has the support of knowing the phone's gonna ring and I'm not alone. When death comes and you switch into bereavement support, COVID has crashed our bereavement support. We aren't having the groups, Zoom isn't the same. And so that volunteer, that same volunteer who became the best friend, calls every day, checking in, because part of grieving is isolation, is that when we're in grief, we don't have the energy to reach out to others. So it is up to us, who are the specialists in the end of life, to be there and support our families. The first week, the nurse calls, that was the primary care nurse, and checks in. That's the nurse's probably last call, but it brings closure to the family, to the primary caregiver, and you need to give that primary care person the closure from this relationship with the nurse. The social worker now becomes the primary person, your bereavement counselor. That bereavement counselor is going to assess how many phone calls a week the social worker or bereavement counselor needs to make. At least 2 that first week, and then assess if it needs to be once a week, twice a week, 3 times a week. But the volunteer calls every day because of the isolation. Every day for a month or 6 weeks. In working with the bereavement counselor, then that volunteer and the bereavement counselor will determine when to cut back to a couple of calls a week or 1 call a week, and then 1 call a month. So you've brought the support that COVID has denied us in the work that we do. Okay. Any questions from that? Anyone questions?
I just want to say how important it is in that intro to be honest, to be vulnerable, to be true with someone, that I am here to care for you. And that establishes a lot just in that introduction. Sorry about the reverb. Also, yeah, the insurance of the team on a constant basis is amazing. Thank you.
All right, let's, questions 5 and 6 have to do with what advice do you have for helping people who work in hospice to recognize and process their own grief, and strategies for combating compassion fatigue? I touched on it a tad when I started about putting your oxygen mask on first, but I will say that what I learned, and I learned it after about a year of working in hospice, and of course, all my patients dying. And I thought, you know, that's what I signed up for, and I'm not grieving. And then about a year after I started, I was kind of a part of a grief group, and I was auditing it so that I could learn to conduct a grief group. That's why I was there. But I'm the one that fell in a little heap on the floor, crying and saying, there are so many ghosts. There are so many ghosts. And what I realized, that with the death of each patient, I just put that death in my pocket and then moved on and brought on 2 more patients. And, you know, that was it. And I realized that we have unrealized grief for every patient that we have that dies, and all of our patients die. And that we need to acknowledge that grief because we gave a part of ourselves to that patient and that family. And we are grieving that loss. So what I learned and what I did, we can't do right now, but I want you to find your own ritual. My ritual was when a patient died, I went to the visitation. I didn't go to the funeral. I didn't go to the memorial service. I wanted to see the body, and I encouraged all of my families to have visitations. Now, none of that applies right now, but the point I'm making is I went on my own dime, on my own time, and I said goodbye. I went to the coffin, I put my hand on the body and said, thank you for coming into my life, and I wish you well on your journey. And then I went to the family and I said, thank you for coming into my life, and I wish you well on your journey. That was my closure. That doesn't work today, but you can think of your own ritual. There are people that I know that have a journal, and when the patient dies, they write that patient's name and a couple of sentences and the date and a couple of sentences about that patient. I know people that go home and have a small altar with a candle, and they light the candle. They say the patient's name. They say, thank you for coming into my life. I wish you well on your journey. And they blow out the light, the candle. Some kind of ritual that gives you closure. I think that's very, very important in taking care of yourself. When I was a primary care nurse during the AIDS epidemic, and there were a lot of similarities that I see today, and that is that we didn't know, we knew it was a virus, we didn't know anything about it, but we knew people were dying from it. We knew it was contagious. We didn't know how it was contagious when it first started. And so there were a lot of the same fears of, I've got kids. Am I bringing this home to them? What if I get it? What if I die? That's a really scary thought when you're working with something that you know is contagious. And so my first person with AIDS was a young woman whose husband had died from a mysterious illness, and that she had caught it also, and she was brought home to Kansas City to her parents to die. The husband had already died. And so that was my first contact with anyone that had AIDS. And what I said to the grandma, grandma, because the young woman brought home a 2-year-old that was failure to thrive. And I also put that in quotes, but at the time we didn't know that he also had AIDS. But that first visit, I said, I don't know what I'm doing. I don't know anything about AIDS or HIV. I do know it's contagious. And I will say, I'm going to teach you how to take care of your daughter safely. And I will make mistakes, but I'm telling you, I will make mistakes on the side of being overly cautious. So that's how I started with her. But I went home that day and I was really scared. And I got in the shower and I felt that hot water wash over me. And I said, oh my God, what am I doing? I'm really scared to be doing this. And I like visual imagery. And so I visualized that hot water washing away not just any germs, not just the virus that I didn't understand or know, but wash away the fear. And as I let that hot water roll over my head, I thought, okay, Barbara, what do you want to do? You don't have to do this. But if you're going to do it, then come to terms with this. And there in the shower, I decided I can do this and I'm going to do it and I'll be fine. And I carried that ritual out throughout the whole time that I took care of that young woman and taking care of her son when he died. And he died 2 years later when he was 4 years old. And in that 2 years, we had learned so much about the disease, about how contagious, how to protect ourselves, just as we will look back in 2 years from now and have such a better understanding of this virus, of this pandemic. But I say to you, develop a ritual now so that after you have done a day's work, that the first thing you do when you go home is you take off those clothes and you put them in the washing machine and you get in the shower and you let that hot water roll and wash over you and mentally see all of the stress, all of the fear, all of the germs go down that drain. And when you feel clean and sparkly, then have that hot water be cleansing, have it be refreshing, have it make you sparkly. So when you get out of the shower, you are refreshed, you are clean inside and out. And then you have a good evening, and then you can do your work the next day. You have to take care of yourself first to stay in this work. And at this time of COVID, you have to address your fears openly and wash them away. Questions? Nope, we're okay.
I believe we're okay.
Okay, let's see. Tips for how to discuss discontinuing treatment, like dialysis, blood transfusion, IV fluids. Well, remind me, well, I'll do the IV fluids first, and then I'll get back to actual treatments, because I don't see IV fluids as treatment. We've got this misconception that we don't want someone to get dehydrated, because dehydrated would be a painful, awful, terrible, suffering death. And that's just not true. But because 90% of our work is education, it's our job to teach the significant others about dehydration, and that dehydration is a part of the natural way that the body dies. You know, our body is programmed to die. It has died the same way since the very beginning. People, animals, they all die the same way the body is programmed to die. And that is that their eating habits change and we gradually stop eating. Our sleeping habits change and we gradually sleep more and more and more. And we start withdrawing from the world around us. We're not interested. We're letting go of our hold on this planet, this plane, and we're building our place in the other world. Part of not eating is how the body dies. We eat to live. Food is the gas we put in our body, in our car, to make it run. And if the body's preparing to die, it doesn't want the food. It doesn't want the energy that food gives. It also doesn't want the fluid, because now in the weeks before death, all the organs are starting to shut down. In the days to hours before death, nothing works right. Well, if in a week or so before death, when labor has started, and I don't know if you're familiar with Gone From My Sight, but it talks about 1 to 3 weeks, the labor of dying. And part of that labor is that the person is not taking in hardly any food and hardly any fluids, because all the organs are starting to shut down. And if you start pumping in a bunch of fluid, the kidneys aren't working right. And so the person is not going to be peeing it out. And that fluid builds up and up and up, and the person drowns to death, which is not a very gentle way to die. The wonderful thing about dehydration is that the calcium in the bloodstream goes up. And when the calcium goes up high enough, the person closes their eyes, they go to sleep, and they don't wake up. God gives us an anesthetic to get from this world to the next. We will sleep through it if we don't interfere with the wonders of our modern technology. The normal, natural way that the body is programmed to die is starvation and dehydration. And that's what you teach your families, so that they understand mom's doing a good job. Mom's doing exactly what she's supposed to do. It is our job to educate the family as to the normal, natural way a person dies. And that's why I wrote Gone From My Sight. And one of the questions further down is, would I change it? Would I add additions? No, I wouldn't, for several reasons. One, if I started adding to it, it would get longer. And families under stress do not have the attention span to read a book. They can get through 13, 14 pages. It's 5th grade level. It's short, it's simple, it's large print, and it covers the basics. And that's all they have the energy or the mind to comprehend. Our job as end-of-life healthcare providers is to fill in the blanks, is to add to that knowledge, where Gone From My Sight is what you leave at home with that family, so that at 3 o'clock in the morning, when dad's acting funny, they can look in that book and go, oh yeah, he's picking at the ceiling and he's talking to little green men. That's okay. He's doing what he's supposed to. But our job is on the visit to sit down and read Gone From My Sight with the family. Our job is to play the 30-minute DVD New Rules with the family and talk about it. Our job is to educate the family in a simple, direct manner. Our work, which Hospice is becoming more and more medicalized, much to my chagrin, because our job is not the medicalization of dying. Dying is not a medical event. It is a social communal event. And our work is to coordinate that social communal event, and COVID has stolen our tools. So we have to be creative. Again, phone, Zoom. If you've got someone in a nursing facility and that nursing facility is letting hospice professionals in, Zoom to the family if you can, or at least call, even if the patient can't respond. You say, I'm putting the phone up to dad's ear. He can't talk right now, but he can hear you. You say what's in your heart, and we'll pretend that my hand that he's holding is your hand. I'm your representative, so that you can ease some of that pain that the family feels of not being there. Questions? We doing okay?
Yeah, this is great. Thank you.
All right. Tips for how to discuss denial of a terminal diagnosis. A young terminal patient with cancer. It's really hard for us end-of-life care workers when physicians aren't honest, because we can't step in before the physician. And how many times have you looked, watched, spoken to people where you know this guy's not going to be here next year at this time? This guy is not going to be fixed. And yet the doctor is still pushing treatment, chemotherapy, all this stuff. And our lips are sealed because it is up to the physician first to bring up the subject. I said, we don't lie and we don't play games. So if someone says to you, a hospice patient says to you, am I dying? What's happening here? First, you ask them what they think, but then you say, you know, nobody knows how long someone has to live. What we do know is when people get diseases that are very, very difficult to fix. And you've got one of those diseases, and we probably aren't going to be able to fix this. But hospice will support you and your family during this time. I wish more physicians were comfortable in saying that. But when a person is on hospice, you can say, you can know, let me reword it. When a person is on hospice, we who work for hospice know that that patient has been told hospice takes care of people that have 6 months or less to live. So they know, or they wouldn't be on hospice. And our job is not to go in and say, look, we've got to talk about it. But our job is to talk about it with whoever wants to talk about it. What and when to sign on ALS patient? I don't know. There are some diseases, and I'll throw in dementia is another one, where they don't really play by the rules. And so it's hard to tell when they have 6 months or less to live. With ALS, it often is how much life prolonging, not equipment, but yeah, kind of equipment, do they already have? You know, one of my ALS patients he became the poster child or poster adult for ALS in Kansas City. His doctor was emotionally invested. He had feeding tube. He went to work with his ventilator and his wheelchair for a while. And finally, he said, "That's it, I'm done." And his physician said, "You are not to turn off the ventilator, the respirator, when he dies. You are to call me and I will come to the house and I will turn it off." I think that physician was so afraid that someone was going to turn that machine off. So I was there during the hours vigil, and we looked at scrapbooks and we talked and we told stories with him in the room, non-responsive. And one of the family members said, "Barbara, how are we going to know when he's gone?" And I said, "I don't know. I'm not sure. We're going to live through this, and at some point we'll figure it out, because I don't really know." And this guy turned purple, head to toe. He was purple, non-responsive, just lying there. And at one point, we all looked at each other and the room felt different. We could hear the machine going. We could see his chest going up and down, but the room felt different. And I hadn't been able to get a pulse, blood pressure, or anything for days. So, tools weren't available. Nothing was working. And we decided that this must be what it's like to die if you're on a ventilator, on a respirator. And so before I called the doctor, I had each family member go in alone and say goodbye. I said, "It'll never be the same after he leaves this room. Say your final goodbye now." And then we called the physician and he came over and he turned off the machine. ALS is a hard one. Dementia doesn't play by the rules either. And you're not going to be able to tell if a person that has just dementia with no other life-threatening illnesses, you're not going to be able to tell if they've entered the dying process until they can't eat. When they put the food in their mouth and they're choking, they don't swallow, and it's determined not to have a feeding tube. And the Alzheimer's Association does not recommend feeding tubes. You can send families there and there's articles. But when a feeding tube is not chosen, then the person will enter the dying process. And that's where you pick up where that person is in Gone From My Side, which means if you don't eat, you don't live. And so you're depending upon how big the body is, how much reserve they have, it will be weeks. You'll just have to figure out how many, and then you can guide the family. What else have we got here? how to have a conversation with family and patients about discontinuing medications. So often we discontinue a lot of these medications and vitamins and all this stuff, and the person actually feels better. You know, our elderly are living with so many side effects of the drugs that they're taking, that life is actually of better quality when we discontinue a lot of these medications. So, you know, you talk to the patient if you've got them soon enough and they're alert and not weeks from death. And you talk to the family and you say, what are we trying to achieve here? We're trying to keep him comfortable. Does he really need to take his omega-3s? Does he really need to take his multivitamin? It's hard for him to swallow now. Aren't we making him more uncomfortable by having him take all these medications? You know, and go through each one of the medications and justify why it should be given or not. So that, again, 90% of our work is education. And if families understand why we're recommending and why we're doing, then they're not going to come back after mom dies and write me and say, hospice killed my mom. You know, when I get that, and I get it a lot, I know the hospice didn't spend enough time educating that and supporting the caregivers.
I believe we have a question. 1 second.
Cool.
Janet?
Okay. I did this a few times, the family or like the son, morphine killed my dad and I don't want to give the morphine because it's gonna do what it did to my dad. And so even if they're in pain, they still won't give it. And you educate, and you keep going back to the same thing.
I know. I get a lot of morphine killed my dad. And again, number one, it's our job to educate the family as to why morphine is not going to kill dad. And what I use is, I've got time. Okay, here we go. My pain morphine spiel. And while I'm thinking of it, get my DVD, New Rules for End of Life Care. There is a whole section in there talking about narcotics and at end of life. And you take that knowledge and you use it with your families, okay? So there is a thin line in everyone's body between pain. Can you see me? Can you see this on the screen?
Yes, we can.
Okay, this is pain right here. And there's a thin line between pain and no pain. And our job is to find that thin line. If we don't give enough, there's still pain, all right? If we give too much, then you're going to have signs that we've given too much. And the first thing, if we've given too much, is that the person's going to go to sleep and they're going to sleep. Now that's kind of an iffy because they can be so exhausted from the pain that finally when the pain has been relieved, they go to sleep because they can sleep for the first time. But you're going to watch that because then they're going to start getting confused. And first they're confused, speech is slurred, and then they may see little green men on the ceiling, and then their breathing is going to slow down and get slower and slower and then their breathing will stop and they're dead. Now look at all the things that we look for that tell us there is more narcotic, more pain medicine than pain. And what do we do when we see the slurring, the confusion? You know, those are when we first start, that says, whoops, we're past the line. And so we don't give the next dosage, or we stretch it out. We may reduce the amount for the next dosage. We're going to play with the pain dosages to find this line. With acute care pain management, and this is what most of us are used to, is we automatically give more pain medicine than pain. Because in acute care, we don't have the time to play with the dosage. Acute care is surgery, is an accident. You're going to address the pain immediately. And so someone has an appendectomy, they automatically get their morphine shot and they go to sleep because it's exceeded the line. You just don't have time. They get a standard dose. With end-of-life pain management, there is no standard dose because everyone's pain is different. All right, so we have to educate how end-of-life pain management works, because taking care of someone at end of life is different than taking care of someone who's going to get better. But most people don't know that. So it is our job to teach them that end of life pain management, end of life symptom control is all different than for someone who gets better. All my pictures are gone. Are you still there?
We're still here.
Okay. I thought, oh my gosh, I'm talking and no one's there.
Well, we're just in awe of the information that you're giving us. It's amazing.
Well, do you have any final questions?
All right, the mic is unmuted for the conference room if anyone has any questions. Yeah, Barbara?
I have a question. So after training a family, a patient can still hear during the dying process, and a family member asks, do you think they are able to comprehend what we're saying? How would you respond?
I really believe a person can hear even in the moments following death. And so I encourage each family member, each significant person to go in the minutes to hours before death and talk to the person and talk to them from their heart. I can't prove that, but my attitude is, what do you have to lose? But I guess over the years, there's just no doubt in my mind that a person can hear. And it's as if what I describe it like is, it's like the person is in a dream and they're hearing sound and voices as if from afar, as if it's a distance from afar. That's the best way to describe it. So how much they comprehend, how much they take with them, I don't know. I haven't died yet. So I don't know. But I believe that they are spending those weeks before death, the 1 to 3, when they're withdrawing from their physical body, I believe that they're processing their life on many levels, on an unconscious level. And in those minutes to hours before death, if we can get the family, the significant others, to go in and individually talk to the person that's dying, it's like life is a billion-piece jigsaw puzzle, and the person who's dying is trying to put all those pieces together. So by significant others sharing their piece of the puzzle, it's making more sense to the person that's dying. But it's not like thinking when you and I are thinking right now. It's different. It's fog, it's removed, it's from a distance, it's dreamlike.
Thank you. Anyone else have any questions out there? Any of the field staff?
I have a question.
Yes.
Barbara, I just want to say thank you. This has been just fantastic. So thank you for today. And I have a question about terminal agitation. You know, this can be beyond just speaking to someone who isn't there. You know, some, families report that their loved one has a leg hanging over their bed as if they're trying to get out of bed, or they're yelling out. And we know that it's very distressing for the families. It could cause lack of sleep and just kind of add on to all the stresses that they're already feeling. So how do we prepare families for this terminal agitation without really scaring them? But how do we best prepare them and talk about that so that they are more prepared if and when it does come?
And it probably will come. It's just different degrees. Different people have different degrees of restlessness, of agitation. And first, part of your education for the significant others is this is gone from my site. These are the things that you may see, because this is part of what it's like to die. This is part of the labor of dying. This is the little chick working to get out of its shell. That's what we're watching here. And that agitation, that restlessness, that chick getting out of its shell, if it gets to the point where you think the person is going to fall out of bed, is going to hurt themselves, then you get the Ativan, you get the Haldol, you use a medication to calm them. I don't think just gentle, random picking, the working the clothes, the sheets, that's not going to hurt anybody. But if they're trying to get out of bed, if they're so agitated in bed that they're going to fall out, then yeah, get some medication, calm them down so that they don't hurt themselves.
Thank you. Anyone else out there have any questions?
I have a question about the word suffering. So a lot of times we have a patient who's actively dying, completely unresponsive, and from a physical standpoint, totally comfortable. And yet the family will look at us and say, he's suffering or she's suffering. And it certainly feels like they're projecting their own current spiritual distress or whatever they may be going through, but they're not always able to recognize that. What's the best strategy for getting them to recognize and overcome the belief that the dying person is suffering?
You're probably not going to get them to see that it's their own projection. But I think what has worked for me is the chicken and the shell analogy, that dad's working to get out of his body. You know, just think of that little chicken, how it works and works and works, and how we want to help that chicken, but we can't. We will interfere with the chicken if we try to help it get out of its shell. This is how the body dies. Now, we're not going to let him hurt himself, but that agitation, that's part of him trying to get out of his body. Nothing bad is happening here. It can be scary, but nothing bad is happening here. And you just reassure over and over, nothing bad is happening here. This is how the body dies. And if all that fails, you get the hell doll.
Thank you. Anyone else?
This has been great fun. I hope that you have not only enjoyed my stories, but have learned from them. Check out my blogs. And if questions come up, send me an email. And I'll write back and try and answer your question. That's what I'm here for.
That was great, Barbara. Thank you so much for visiting with